Okay, I guess I'll start. So I'm going to talk about stature, lengthening, indications, technique, and results. And then Mark asked me to do my last talk all together so we don't have to connect and disconnect my computer. So that's fine. So what I'm going to tell you is published in Techniques in Orthopedics, Volume 30, Number 3, 2015, in an article entitled Stature Lengthening Using the Precise Intramedullary Lengthening Nail. The controversial questions is, should we agree to lengthen anyone for stature? Should we base this decision on a height threshold? Should we base this decision on psychologic factors? Should we base this decision on ability to pay, as with other cosmetic procedures? So the height threshold is very arbitrary. What do I mean by that? Well, you know, when I first started, I had an assistant named Harry. Harry was 5'4", and in centimeters, that is 162 centimeters, okay? So it was the low end of normal height. And so people came to me for stature. I said, if you're taller than Harry, you're too tall and I'm not lengthening you, okay? So every year we increase the height threshold, you know, a little higher, 168 centimeters, 175 centimeters, and so on. I remember then this guy flew in from Amsterdam and he was 182 centimeters and he wanted to be taller, okay? He was my height. Seriously, you want to be taller? I sent him on the next plane. Now I would lengthen him, okay? Why? Because, we're going to talk about it, he suffers from the same problem as all these other people suffer. And that is a body image problem. So stature issues are body image issues. I'm going to talk more about that. Certainly, lengthening someone 182 or 152, the 182 is a smaller proportion of length. So it shouldn't be an increased risk. It might even be a decreased risk. You know, is the benefit greater for shorter versus taller people? You know, again, what I've learned to do, I'm no longer judging people. So you know, you talk to your plastic surgery friends, you know, breast surgery, make them a little bit bigger, a little more bigger, a little more bigger. Everyone has their own size they want something. Everyone has, you know, they want it this way, that way. The plastic surgeon is the technician. He's not there to say, no, you know, I only may go from A cup to B cup, never to C cup or to D cup. You know, that's not, unless it's dangerous. So our job is not actually to be the judge. Our job is to do it as long as it's reasonable and we can do it safely. And I've learned that. So I've gradually become a cosmetic plastic surgeon, cosmetic orthopedic surgeon in part of my practice. So the risk benefit is no different for short or long or taller individuals. And I think that's part of the reason. Psychologic factors. So is height neurosis a real entity? It's got two names, height neurosis, which is the name I gave it, and stature dysphoria, which is the psychologist we used, he gave it that name. Dysphoria is the opposite of euphoria. Dysphoria means not happy, okay? So unhappy with height. So body image is affected by height. And this is probably the primary motivation of most people who want stature lengthening. They're not coming to become a better basketball player. They're not coming because of, you know, most of them are coming because they see themselves as short. It doesn't matter how you see them. I think that's what I'm trying to tell you. So you might look at someone and say, you know, you're 176, 5'8". You don't look so short. I mean, to me, you look fine, okay? It doesn't matter what you think. It doesn't matter how it looks to you. It's how it looks to them. That's what you have to start realizing. And the moment you realize that it's how they see themselves, then you have to put yourself in their eyes, not them in your eyes. Then you begin to understand them. And they've suffered from this for a long time because when they were younger, they had this body image problem. Even if they were 154 and relatively short versus if they were 178 and really not short. Even if they were second percentile for height versus 70th percentile for height. If they see themselves a certain way, you're not going to change that. You can send them to a psychologist for as many visits as you want, it will never change it. You cannot change that switch except with surgery. And we'll talk about that in a minute, but you can change that switch. And only by changing their body, because that changes their image. And they grow up, people make fun. This is part of the problem. It's called juvenilization. It's treating them as younger than they are. That tends to happen. And so, you know, because you're shorter, you look like a smaller child. So therefore, you get juvenilized. So there's many aspects. There's many, many papers. I've read so many papers on this. And there's a great book. It's not in print anymore, but you could find it. It's a quick read. It's called Too Tall, Too Small. Okay, it's an old book, very worthwhile reading. You know, there are many things affected by height. If you look, the presidential election is suspected to be affected by height. The taller candidate has won in all but one case. Okay? And in fact, when they take the video of the candidates, they make sure that they shoot it from certain angles not to affect how it looks height-wise. The other things are affected by height. Income is affected by height. Even to this day, studies show that height increases your income in many jobs. Glass ceiling effect because of height. You can't get past certain things. Now, you know, I don't know if it's the height, but the height leads to other things. Lack of confidence, lack of, assertiveness, other things, which probably is what affects, some of these factors. Mating options certainly is a consideration. Being too tall as a woman or too short as a man is discriminated against unconsciously, but it is, and it affects mating options. So there are many things affected by height that affect psychology. Cost. Insurance companies won't pay for cosmetic stature lengthening, even in socialized countries. It's very expensive. In the United States, it's $85,000 to $90,000 at our institution if there are no complications, but if there are complications that require surgery, it could cost more. Many patients who are good candidates for this can't afford this much money. This is more expensive than most cars. Should a surgeon consider financial hardships when agreeing to do the surgery? Especially when I've just told you this is a true neurosis, a true psychologic condition. Shouldn't we be treating this? So how is it stature lengthening different from other cosmetic procedures? Well, there are significant psychological demands of the treatment. The treatment is prolonged. Disability is more prolonged than other treatments. If you have a nose done or breasts, you don't need an inpatient surgery. You don't need a lengthy treatment. You're not in a wheelchair or crutches for months. So this is a very stressful treatment compared to other cosmetic procedures. Intense, long rehabilitation. You don't need that with most cosmetic procedures. Pain. Not much pain with most cosmetic procedures. There's much more with this. And it's much more labor intensive also on the medical staff. We have to spend much more time, physical therapy, visits in the office, and so on. So we did a study when I was still in Baltimore of the psychologic profile of stature patients. We looked at 30 prospective, that means they hadn't had surgery yet, stature patients, and from 1999 to 2003. 21 males, 9 females, average 28.7 years old, aged from 16 to 45, and most were educated, 16 years of education, so these were a more educated group of people from 10 to 22 years of education. Average pre-surgical height was 162 centimeters, or about 5 foot 4. And in the women, it was about 5 feet tall, or 153 centimeters. So this group of patients were, on average, more on the shorter end. We did a clinical interview with our psychologists. One psychologist did all of this, MMPI, other tests, including Rorschach. 17 of the 30 patients, or 57%, were considered psychologically fit to proceed to surgery. 12 had surgery, and which was 40% of the sample. And then 9 of 12 in that study, 8 males, 1 female, were followed up, and the mean interval of follow-up was about 5 years, and mean height gain was almost 3 inches, 7.4 centimeters. And what we found is that 4 patients strongly agreed they were satisfied with the outcome. Now, the treatment then was with the ISKD, much worse treatment than today. No subject was neutral or negative about this. Subjects tended to report lengthening and address their problems. I'm sorry, 4.4 and 5 are scores, not number of patients. So the highest score was 5, and so the mean rating was 4.4 out of 5, which is very high. Lengthening had addressed their issues, meaning their height neurosis, whatever bothered them. That was 4.2 out of 5, again, extremely high. And they were very uncomfortable about telling others about their surgery, and the score was about 2.2. So many of them are actually open about this. They're not uncomfortable about telling others about their surgery. Now, we did find a correlation between decreased dysphoria, that means unhappiness about their height, and good outcome. Okay? So if you had a good outcome, they were very happy about their height. Because we did it with the ISKD, there were a lot of poor surgical experiences. I think this would be different today with the precise. And so we found there was a decrease in stature dysphoria, okay? That's what most correlated with a positive sense of treatment outcome. And subjects reported they were less tense and dissatisfied after lengthening, and less preoccupied about their height, so a score of 4 out of 5. And in general, subjects reported having more pain than they expected. Again, the ISKD was a more painful treatment than the precise. Those with the most positive attitude reported the most negative surgical experience. I'm not sure what that means. The lengthening, so what's our lengthening goal? What I currently do is ask the patient, what's your goal? And some of them are ridiculous. They're 152 centimeters and they want to be 182 centimeters. Okay, but that's too much. 30 centimeter increase, that's not going to happen. So we have to make sure that they have a reasonable goal. And the range of goal that's reasonable, I have found, is anywhere from 5 to about 15 centimeters. And 15 is at the high end. And we can discuss how you get there. There are many combinations of lengthenings, but anything more than about 7.5, 8 centimeters requires 2 lengthenings. The nail can only do 8 centimeters in one bone, and it's not reasonable to do more length in a single bone. So you shouldn't do more than 8 centimeters in a single bone. When they designed the precise nail, the original was 6.5 centimeters. I wasn't involved as a consultant back then. When I got involved afterwards, they increased to 8 centimeters. That number came from studies that I had performed and where the complication rate increased significantly after 8 centimeters. Now, Albizia nail went up to 10 centimeters. And they said we could go up to 10, and I asked them not to allow the nail to go to 10, to avoid the temptation to push to that level. Because if you give people up to 10, they will go up to 10, and you get into much higher risk of complications. So the nail only goes up to 8 for a reason. And muscles, probably more than 8 centimeters lengthening in any muscle, including in achondroplasia, at one go is too much. And you're really getting into potential muscle damage. So we look into the patient's goal, but we also need to make sure the goal is reasonable and the goal is achievable. And need to make sure they understand how long they'll be on crutches. That may all change with the new nail that's coming out, how much time off work, and so on. So we start with the initial patient evaluation, history, goals, judgment, realistic, support, finances. All of that's discussed. And if they're married, I want to make sure that their spouse knows about this, because many times they don't. I've had patients who are willing to mortgage their house without their spouse knowing in order to pay for their surgery. Physical examination. I'm going to talk about this in a minute, the muscle length tests. This is an important part of every lengthening surgery, but especially here. These are the Popliteal Angle, prone knee bend, Ober test, and Silverskiold. I'll show you these. And then radiographic. So the Ober Sign tests for how tight is their fascia lata iliotibial band. And you basically, the patient lies on their side, you pull on their leg and you push on their butt into full hip extension, knee at 90. The leg stays up in the air. I'm not supporting the leg. That's the fascia lata holding the leg like that. And so that's a positive Ober sign. If it's at horizontal, parallel to the floor, it's neutral, and if it's below, it's negative. So positive, neutral, negative. If the Ober sign is negative, is the only indication I won't lengthen the iliotibial band. If the Ober sign is positive or neutral, I always lengthen the iliotibial band. Popliteal angle, very important because you want to see how tight their hamstring. Why are we doing muscle length tests? Because when you do, and this is important if you're going to be a limb lengthening surgeon, and I see this all the time, nobody does muscle length tests. When you do a lengthening with any device, you are doing a muscle length test, right? You're lengthening that bone and therefore lengthening the muscle. Wouldn't you like to know how much reserve the muscle has? So hamstring's a good example. If you can have a 0 popliteal angle, that means you can flex the hip to 90, the knee stays straight. I can't do that. So if you can do that, your hamstrings are really have a lot of reserve, right? Because what are we trying to avoid in the hamstrings? We're trying to avoid a flexion deformity with the hip in extension, not with the hip in flexion. So if you've got 0 popliteal angle, you have a lot of reserve. That muscle really can stretch a lot. You're going to probably not get into problems with the hamstrings, okay? If you lie prone and you have a positive Ely test, which means the rectus femoris is tight, you have no reserve. Your rectus femoris is already tight. That means when you start lengthening, you're already in trouble with inability to lengthen the rectus. And therefore, you start losing knee range of motion. And you may get a flexion contracture at the hip, too. In the ankle, I think everybody knows this better. So if you are doing a tibial lengthening and you cannot dorsiflex the foot past neutral with the knee in extension, you're in big trouble. Okay? So yeah, you don't have a contracture yet. But give a few millimeters of lengthening, you will. In other words, you can't already bring it above neutral. How do you expect to add length and not be in equinus? Okay, sure, with the knee bent, the foot will come up. If the patient wants to walk around squatted all the time, that's a great idea. Okay? But most people like to have their knee straight. So if you want to avoid what the patients call ballerina foot, which is equinus, you have to be very aware of this. This may be an indication for soft tissue release, but that has its consequence. If you do a gastrosoleus recession or even a stray or a gastroc recession, I can tell you that you never recover to full strength. Never. Okay? Even with lengthening, with everything, if you really measure it carefully, you never recover to full strength. So for cosmetic reasons, I won't lengthen the gastrosoleus. Just won't do it. Okay? And you can do a temporary arthrodesis screw from the calcaneus to the tibia. With a frame, you would immobilize the foot and hold it there. That might be reasonable, but I don't like lengthening the gastrosoleus in cosmetics. These are normal people. And it's not a good trade-off to trade function for length. So I won't do it. And so these are the things I'm looking for. So then we do the x-ray. We have an EOS machine, so I like that. But you at least need to have this long x-ray machine to assess alignment and lengths and diameter. So length, diameter, alignment. Those are what we're looking at. The EOS machine allows you also, and also leg length discrepancy. It's surprising how many people are walking around with a 1 centimeter leg length discrepancy without knowing it. Now when you tell them and they're going to undergo bilateral lengthening, they see it as an opportunity to equalize their leg length. So even if they're doing an 8 centimeter femur lengthening, they might do 7 centimeters on the long side and 8 centimeters on the short side to equalize. So you want to know this. You want to know the ratio of the lower limbs to the body. The normal range is 50 to 52%. The limbs are maybe slightly longer. How do you measure it? I measure a line from the center femoral head to center femoral head, and I measure a line from the top of the head. So you could actually measure from here to there and get an accurate measurement. I don't measure the length of the legs because you can't find an accurate point on the ground. So instead, I take their height. So to get the length of their legs, the height is an accurate measurement. You measure that in the office. I take height minus the length from the top of the head to the line across the femoral heads, and that gives me the lower body. And the ratio of the upper body to the limbs, the limbs should be 50 to 52% of the total height. Sorry, so it's actually the limbs to the height is 50 to 52%. So most people are normal proportion. They all come in saying, oh, my legs are too short. And then you measure, they're not, okay? That means that when you lengthen them, you are making them disproportionate. People ask about that. They don't want to be disproportionate. There's no way to do cosmetic stature lengthening. In dwarfism, yeah, you make them proportionate. But in this, you make them disproportionate. So the good news you tell them is, if you look at models, if you look at what people nowadays think is beautiful, okay, people like long legs. Models like long legs. You know, you look at the bathing suits, they cut them high, which makes the legs look longer. If you look at all the runway models, they all try to make their legs look longer. So having a disproportionately long leg is not unattractive. It may be more attractive. So they like hearing that. The second proportion is you look at the tibia to femur length ratio. The normal tibia to femur length ratio is 78 to 82%. So it's 80 plus or minus 2. Okay? That's one standard deviation. So it's actually wider than that. But so people who have, for example, 0.75. 0.75 means your tibia divided by your femur, your tibia is proportionally short, right? So 0.75, you should think twice before you do a femur lengthening, because then you're really going to have an obvious difference with long thighs and short leg, okay? On the other hand, if the number was 0.82, so it's normal, but that person is a great candidate for femur lengthening, because you're going to move them more into the normal range. And so this gives you an idea beforehand. So I always look at the tibia-femur ratio. If they're lengthening both femur and tibia, it doesn't matter. But if they're lengthening only one bone, you really want to look at this ratio. We measure off this x-ray the medullary canal diameter, since the nail comes in 3 diameters. We look at, by the way, so you're all trained in trauma. So first thing to do, I don't know if anyone told you this in this course. So do not approach lengthening with an IM rod with the rules you use for trauma. Have you noticed we use short nails? None of us are nailing the full length of the bone, okay? You don't need to do that. It's a straight nail. It's actually easier not to do that. The second thing is we don't determine the diameter of the max, whether we can put a nail in a bone based on its medullary canal diameter. We actually determine it based on the width of the entire bone, especially in children. So the canal might be 6 millimeters. You say, I can't do it. Smallest nail is 8.5. It's not true. If the total thickness of the bone was 16 millimeters, but the canal is 6 millimeters, just ream it out. I only look at the outer diameter of the bone, not the inner diameter of the bone, especially in children and to a lesser extent in younger adults. In older adults where you might be removing permanent bone stock, yeah, I look more at the inner canal of the bone. But don't look like a trauma surgeon and only look at the canal difference. You look at the whole width of the bone on AP and lateral views. We look whether the physis is open or closed. I won't do cosmetic stature lengthening if the physis is open. I think all that pressure could lead to growth inhibition, so you're going to lose some height. And now it's different in achondroplasia, but for stature, normal people, physis closed. So this helps you determine nail diameter and length and your entry points. I don't have to talk about the precise, but I do want to show you, this is the incisions I use. There's a 1 centimeter incision in the buttock, 2 5-millimeter incisions for the screws, 1 5-millimeter incision for the osteotomy, and 2 5-millimeter incisions here. I still don't understand why people make an incision like this to do a femur osteotomy. So I don't know how many of you make a 5-millimeter incision to do a lengthening osteotomy? How many of you make a much bigger incision? Be honest. So now you can't all answer. You have to ask yourself why. And here's the answer you're going to say: I need to see it to be safe. There's a thing called an image intensifier. If you really need to see it, press the button. You do not need to physically see it. There's nothing to look at. Stick a drill hole from a safe side, make a few holes, take an osteotome, preferably sharp, that wasn't used to remove a plate in the morning, and hit the bone. There's nothing you need to see. This whole thing of periosteal, 2 homins, this is like 1960s. We're in the 21st century. There's no need to do all that visualization. It's probably more harmful. That whole technique Orthofix sold us with open periosteal elevation, this is nonsense, okay? Lazarev actually showed us this, percutaneous osteotomies. I've been doing it since. I have never injured a nerve or a vessel because of this. So I think it's an important skill to learn to do percutaneous osteotomies. For these cosmetics, they don't like big incisions. That's another reason. We know about the performing of this at home. I'm not going to get into it because we're dealing with P2.2, but the first nail had these welds, P1. Second nail had a crown, which would break, P2. P2.2 has no welds, no crown. All these other issues are historic, of no great interest anymore. But they were part of our learning curve. So here's a 25-year-old man, 5'4", 162 centimeters, bilateral femoral lengthening, the reaming, pre-drilling, so the reamings come out the osteotomy. I didn't get to talk about technique, but in the tibia, I do not pre-drill. I do not make fasciotomies. I do not even vent. I don't really care in the tibia. I've never had an issue with fat embolism in the tibia. If you want to pre-drill, just make one vent hole anteriorly. But the tibia doesn't heal well, so drill holes create a bone defect. So I don't like to pre-drill in the tibia at all. And if I do, I'll use a 1.8 wire, very small holes. So I don't have these little bone defects which are 4 or 5 millimeters in diameter, which in the femur is fine. As someone said earlier, if you ream before, the reamings are going to come out the holes and into the compartment. Which compartments? Everyone thinks the anterior compartment, which is true. So that one's easy to decompress, right? But the problem is the other compartment is the deep posterior compartment. And I've seen these. People get swelling and compartment syndrome, the deep posterior. And that's just much more of a pain in the ass to decompress. Anterior compartment, you can make a 1 centimeter incision, cut it with some instrument. There's fasciotomes, there's scissors. Deep posterior, you're not making a 1 centimeter incision. You're making a probably 5 centimeter incision. Going down there, going up, going down. It's a much bigger deal, okay? I guess if we decompressed both compartments, then you could drill. But here's the consequence. These are cosmetic. What do you think happens when you do an anterior fasciotomy? Or even deep posterior? Okay? Do you know what a genie is? You let the genie out of the bottle, and you can never get it back in. The compartment is always under tension, always. And it comes out. And it looks ugly, and they hate it. So you're doing a cosmetic procedure, and you're giving them a permanent deformity of the muscle. It bulges out. The women are really upset by this. So I made that mistake once. I'm a quick learner. I did not make that mistake again. And do not do fasciotomies. But you don't need to if you don't pre-drill. And I don't even prevent. And although this is preventing the complication. I just do the osteotomy. I do one thing for the osteotomy that's different. Tibia, you know, femur is easy to break. Even without drill holes, break the femur, and it's a round bone. It usually breaks right across. The tibia, on the other hand, I don't know if we've talked about this, tends to develop either a big butterfly fragment or a big spike. Sometimes the spike's in a good direction, sometimes it's in a bad direction, especially posteriorly, especially proximally, and it can destabilize your fixation. So I make 2 incisions in the tibia, one anterior, one posterior medial, both only 5 millimeters. And I start posterior medial. And I use my osteotome going across. And I leave it in there. Now I come in anterior lateral, aiming for my other osteotome. When you do it that way, it usually breaks right across, and it doesn't butterfly, okay? So I always start posterior because that's where the butterfly will be. So by cutting across, I guarantee that there's no butterfly. And then when I cut from the front, I join the back one, and I don't even pre-drill. So I have good bone-to-bone contact, better regenerate. Okay, so I use 2 incisions now. Here's the reamings. The reamings are very helpful in the femur. Lengthening, this was 6.5 with the P1s, and then healed very quickly. How long does it take to heal? If you're doing an 8 centimeter lengthening, in most people, we're lengthening 1 millimeter a day. In older people, we lengthen 3/4 millimeter a day. But it takes, for an 8 centimeter lengthening, about 3 months of lengthening, right? Latency period a week, 80 days of lengthening. So at 87 days, it's almost 90, that's 3 months. And at the end of the 3 months, you've got a big gap, it's still not healed. Most of those patients will take 2 more months until they can be full weight bearing. So on average, I tell patients 5 months for an 8 centimeter lengthening. In the femur, if they do a 5 centimeter lengthening, okay, you're about 2 months of lengthening, 50 plus 7 of waiting, so it's 57 days. And most of them are actually healed in 4 to 6 weeks, okay? So less lengthening, less consolidation time. All of that is plus or minus a month. I let them off of crutches at that point based on radiographic. Walk the first month, run the second month, contact sports the third month. That's my routine. Now again, all that may change with the new nails. Tibia, we've talked about. I'm very, I talked about the inclined screws, so I don't know if you've seen that, but I always put my screws like that from the tibia. I drill a wire from fibula to tibia, and then retrograde cannulated drill from tibia to fibula. And now I use the precise screws. They're stronger, 4 millimeters, they work very well. I try to lock through the nail, but if I can't, I put an extra screw. Now, this was a P1, early case. Look what happens. He heals, but if you look carefully, he broke through the weld. Fortunately, nothing happened. Fully healed. This is not an uncommon finding, is that in the anterior tibia, we will see this deficiency. It often is made up by increased bone in the back, so probably net, you're strong. And I ended up removing this. This was him. Femur lengthening, a year later, tibia lengthening, total of 10.7. And that's what he looks like on the EOS scans as he increased his height. Another one, this guy was a 52-year-old cardiac anesthesiologist, and he says, I understand the risks of fat embolism. Don't you think? I'm a cardiac anesthesiologist. He says, I want you to put all 4 nails in one time. So I did a TE echo so I could listen to all my fat emboli as they went by the heart on the way to the lungs. That made me feel much better. I even tried the reamer aspirating system. That actually created more fat emboli than the normal reamer. So much for that great idea. And when I did the femur, you had the most fat emboli. You had less when I did the tibia. I could listen to them. This is a really bad idea because it increased my blood pressure, not the patient's. The patient did perfectly fine, woke up, never had an issue, never had a fat embolism, was totally happy. And, but having said that, I have had a handful of fat emboli. All of them have been in bilateral femur cases without 4 segments, just 2 segments. How do we detect them? Patient, we never had an episode in surgery, but the patient woke up with the pulse oximeter dropped down in the first 24 hours. You send them for a CT of their lungs, nothing. You get an x-ray a day or 2 later, you look like you have aspiration pneumonia, okay? But pulmonologist comes back and says, no, actually there's nothing in the lungs. This is all it is fat emboli. It's always peripheral. And they resolve so far. We haven't treated them. They've resolved so far. This is a diagnosis of exclusion. There's really no good test unless you see petechiae, which I've never seen. So all of them have resolved by giving them oxygen, usually nasal prongs. In one case, I actually gave them mask oxygen. Never went to the ICU, any of them. One of them stayed in hospital 7 days because it took a long time to recover. He actually felt sick for 7 days. All the rest didn't even know anything was wrong, just the pulse oximeter was lower. I've had a total of 4 of them in about 100 cases. So it's about 4% incidence. And I've done 2 4-segment lengthenings at once, and both of those didn't have anything. So I don't understand. So here's this guy, had bilateral femurs and tibias simultaneously. We lengthened about 10 centimeters. Here's his consolidation. And then this is a year post-op. He sent me this video of him trail running. And so he's not fully rehabilitated, but I mean, this guy was just doing everything, weights, running. He's 50, he's now 50. At the time, he was 53 years old for this video. And, you can see, I mean, this guy took this very seriously. So he fully recovered, obviously. He came back the following year. He says, they're still lengthened my nails. So he wanted us to lengthen his femur. So I rebroke the femurs and lengthened the other 3 centimeters in both femurs. He's an avid skier, avid rock climber. So, you know, our patients are recovering. Our patients do not have functional deficits. They're returning to previous level of sport. The amount of time it takes depends on how much they work, like this guy. You know, here's a bilateral P2s in a 44-year-old man, and we lengthened out and healed. He got 8 centimeters both femurs, and here he is. He's taller than me. So he is over 6 feet tall, 6'1", okay, but 184.5 centimeters, something like that. So again, I no longer have a height threshold. So we looked retrospectively from June 2012 to June 2014. So these are not P2.2s, these are P1s and P2s. 51 patients, 25 P1, 26 P2. 58 were P1s, 58 to 58 P2s. 6 females, 45 males, so mostly males, you can see. Average 28 years, but the youngest was 15, was a woman, so because she was skeletally mature. Mean height pre-op was 164.7. So it ranged from 150 to 180 centimeters in initial height, okay? 25 P1 patients, 18 femur, 3 only tibia, and 4 femur and tibia sequentially. In the P2s, we had 22 only femur, 1 only tibia, and 3 femur and then tibia. And the lengthening amount was an average. In the old nail, you could only go 6.5. So if we did the study again, you'd see that the amount is more now because we can lengthen 8. So the goal was the same. They achieved the same. The only number that was off was the MPTA. We did get a little bit of valgus, and now we put a blocking screw, and we don't get this problem anymore. We had very few complications except for nail failures and mechanism failures, but that's a problem for P1 and P2. We don't see that with the P2.2, so I'm not going to spend time. The other complications, DVT, we put all patients on Xarelto from day one. I mean, from discharge. So they're on Xarelto until they fully weight bear. For 5 months, they're on Xarelto. Fat embolism in this particular group was 2. As I say, I've had 2 more since then. And screw back out, 2. Fracture through a locking screw, 1. And TFL contracture, 1 who refused to allow me to lengthen her TFL. So everyone else had their TFL lengthened. So we cut the TFL at the level of the patella. So distally, right here, we cut it in everyone. Transversely, it regenerates. You could come back and it's completely as if you never touched it. And 1 bilateral perineal nerve injury, and this guy had very tight popliteal angle. I lengthened his biceps and his medial hamstrings, and I created the nerve injury in surgery by stretching his popliteal angle to 0. He woke up, dropped feet. I went back, decompressed the nerve. He fully recovered, but it took him almost a year. So remember I talked earlier, don't put this screw in? This is a fracture that occurred that went through this screw and another screw, 2 screws. So the anterior thing is a stress riser. Don't do that. And we had to do a fixer-assisted rod replacement for that. So the results, we had an average 5.2 centimeter lengthening. Now our average is higher. Mean height gain was from 3 to 10.7. The 3 was 1 patient with the P1 that the mechanism failed bilaterally, and he didn't want any more length. He was only going for 5. The goals were achieved in 100%, full bone consolidation 100%, return to activities 100%, and no limitations, no pain. There were complications, as I told you, with nail breakages in the P1s in particular. You see the breakage through the welds, and that's what the bone looks like a year after removal. I remove all my rods. These are weird metals in there, rare earth metals, and if the fluids get in there, I don't know the effect of that, so I remove them. They also end in the middle of the femur, so you get a stress point there, so I remove them. This was one that failed to distract with the P1. See, it didn't open here and it opened here. It's not premature consolidation. That's a failure of the mechanism. The mechanism has been improved, so I've never seen that again in a long time. One thing I do is I always test my nail in surgery, lengthen a millimeter. We had a series of nails that did not lengthen. And I know, Rob, you don't test them. And they must send you the good nails. And they must send all the crap to me, because even as recently as a few weeks ago, I had a nail that did not lengthen in surgery, okay? And, you know, especially in a cosmetic patient who's paying for this, they're going to go back to surgery to have a nail exchange. This costs the system or them money. We've combined it with high tibial osteotomy, as you can see here. So here we did HTO and simultaneous lengthening. And this guy, this is the old, this is a mistake on my part, not cutting the bone high enough or not using a longer rod so that I had more overlap. Puts a lot of stress there. The P2 crown broke, and eventually the nail broke. And I had to replace that. So I think it's a combined mistake. How do you get these out, these broken fragments? You have to go through the knee. I put a rush rod through the knee and bang it out from below. So that's actually the quickest way. It takes me 5 minutes, the nail's out. So you can't pull it out from the top. It's very hard. Don't waste your time. Just bang it out from below. And find your old rush rods or make a drill hole, get some old rod that's that long, hit the nail, and boom, comes out. So there's many learning curve problems that most of you won't have to experience. We went through this with the ellipse and, company originally, now Nuvasive. Such as the AP screw in the femoral diaphysis. We had to learn that the hard way. There's excellent rate control, reliable lengthening. The reverse mechanism does work. We have used it occasionally. The P2 is more reliable than P1. P2.2 is more reliable than P2. In the future, we're going to have stronger nails, either stainless steel, cobalt chrome, thicker wall diameter. All those mechanisms have been looked at. The new one's going to be called the Stride nails. It's going to be coming out this year on limited release for us to test, probably general release next year. These are some of the early testing results to show you. I mean, the yield load, that's when it really breaks. There's going to be an 8.5 nail. Its yield is 208. These are in pounds, sorry. The United States, we're still on this old system. 10.7 nails, 325. 12.5 nails, 546. But what's more important is fatigue load. So that's from repeated million cycle testing. And you can see the 12.5, I'm sorry, this is, should be looking down here. This is the Stride, this is the P2 nail. This is the current nail, sorry. So the current nail, that's the loading, but here's the fatigue load. 67 on the 8.5, 118 on the 10.7, and 146 on the 12.5. So 146, is most of my adult patients are more than 146 pounds, okay? I mean, that's less than a 70 kilogram man. If you look at the new nail, it has the 10 millimeter nail, it's going to come in 10, 11, 5, and 13, has 343 pounds, and the 13 nail, 677 pound yield strength. And it's what do you call it, fatigue load will be 167 for the smallest diameter nail, and 320 pounds for the 12.5. So if you can put a 12.5, the fatigue load is 320. That's why you can let them fully weight bear. So this is very encouraging, very exciting, and I look forward to using that, because if you ask most of these patients, their biggest complaint is the chronic use of crutches, wheelchair, walker, all that. So this will be a game changer and allow patients to walk without crutches or minimal crutch time and get back to work much sooner in a bilateral mode. So that's what's coming. That's what I have to say. I've changed that. No, I have now minimum 3. So I do 3 centimeters. I had actually at that time 2, but sometimes you mark on skin and where it ends up, it's a little off. And is there a downside in just going with the longer I do a longer nail now. So I was using a shorter nail to avoid straightening out the bow of the femur. I use now a 275 nail instead of a 245. So remember, these are P1s, P2.0s, and if you looked at this ends in 2014. If you look at a more current series, you would see, which we haven't done a study on, you would see that we use 275 nails and we have more overlap. And we haven't had a breakage or any issue with those. But we're also very religious about our protection of weight bearing. And every patient is told about these other patients. I show them a picture of a broken nail, you know, and that stays in their mind. And from then on, you know, usually we get good cooperation.
Do you use any muscle stretching program or protocol or physical therapy before this operation?
No, I think, you know, Guichet's talked about that. I think it's nonsense. You look at any chiropractic data, any stretching data, the effect of stretching lasts 24 hours. So I don't think it makes any difference to do all this stretching stuff for weeks and months ahead of time when it wears off. It is important once you start this process. Now, maybe it's useful to get in the habit of doing it, but I don't think it hurts. I just don't think it's that important. Guichet even recommends increasing their muscle mass beforehand because you're going to lose a certain amount of muscle mass. I think that's all really nonsense. I don't bother with that. But what you do need is a very good rehabilitation program. I'll tell you what I don't do. So I don't, and feel very strongly about this. I don't take a Stature patient who comes to West Palm Beach, Florida, and says, no, I'm going to go home and lengthen. Then I said, tell them to go somewhere else. I won't treat them. They want me to treat them. They're going to stay locally. They're going to be in our rehab center with my therapist with, you know, 1 hour a day therapy, 5 to 6 days a week, do home exercises, and they do not get to leave town until the end of the distraction phase. They're going to come to the office every 2 weeks for follow-up with x-rays. And we're very strict. And what we sell is safety. Tell them, you come to us, we feel very responsible that you walk out of here with equal function to you have now. And that might sound easy, but it's not. And the chance is you'll lose some function, even subtle function. And I'm not willing to trade your function for this. And I don't think you should trade your function for centimeters. So you want that, you come here. So we actually now have very strict protocols. We don't negotiate price, because I got into that in the beginning. This one wants a discount, that one, nope. This is the price. We don't negotiate method. This is the method. We don't negotiate anything. Smokers are not welcome. You know, on and on. We're very, very strict. I don't need it. It's fine. I just want to treat people who are compliant, who are motivated, and so on. I mean, I don't want to be criticized. You get enough criticism from your colleagues for doing cosmetic procedure. But I do a cosmetic procedure in a responsible way. And I think that's my best defense. John.
Sure. Thanks for sharing that data. I want to ask you specifically about some of the soft tissue releases, like the fascia lata, when you're doing femoral lengthening.
Iliotibial band, not the fascia. So I like to call the fascia lata the proximal part. And I mean, it's semantic, but it's important because there are certain conditions where we do a fascia lata release. In other words, cut the IT band over the greater troch. The fascia lata. So for example, for a congenital, I cut at both ends. If I'm not doing a fasciectomy, I cut at both ends. For a dwarf, I cut only proximally. So there's an indication for each. And for these, it's only distal.
What's the rationale for doing it? Because I thought you said in your
but have you ever tested? So when you've tested hundreds of people for an Ober test, you'll discover it's positive in everyone. It's normal. You want to know the only people it's not positive in? Like some of these dancers, some of these gymnasts are so loosey-goosey that, you know, they have a negative test. And by the way, so the last time I didn't lengthen the iliotibial band was in one of these dancer gymnast type. And guess what happens? They get too tight. So I think 8 centimeters overwhelms people. People can get away with up to 5 centimeters. In the online, you know, the chat rooms, do you know what they call that when you get a tight fascia lata? So what happens is you look like this, okay? Because you have flexion deformity and your butt sticks up. So they call that duck ass deformity, okay? And in addition, if you look carefully, they're internally rotated. So they get this internal rotation, duck ass deformity from lengthening.
For your more routine lengthenings, like a post-traumatic 3 centimeters, are you cutting the fascia lata distally?
For unilateral leg length difference, no. No, it's these statures with 8 centimeters, and I don't cut, you know, in a developmental case who's not particularly tight and so on, doing 5 centimeter lengthening, I won't cut it. The other thing is those patients have insurance. And I know that shouldn't make a difference, but it does. If you have insurance, if you have a complication, it's paid for. I can come back and lengthen your IT band later. If you have a complication as a cosmetic stature lengthening, and you just paid $90,000 for your treatment, that's hospital, nail, you know, physical therapy, it's the whole thing. And you finish everything and you have this duck ass deformity and you work on therapy for a year and it's still bothering you, and you have to now have your IT band cut, which is in the United States, $15,000 to do that, okay? Who's paying for it? They are. And so it was happening with the smaller amount of lengthening so often that we now do this routinely. What's interesting is if you examine them, when they come back for their nail removal, I examine their IT bands. So I see the scar, but you examine, you feel the IT band, even the edge of it. It's 100% recovered. And then occasionally I've had to open that area, like maybe to remove screws or something, and I'm looking, and it's like a normal IT band. So I think of it as a corticotomy of the fascia, not a, it's cut as straight transverse. I also cut the intermuscular septum, and I retract distally, and I find the biceps muscle, and I do a recession of the biceps. So every one of these actually has had 3 structures cut: the biceps, the IT band, and the intermuscular septum.